Well, good evening and welcome to this NHS webinar. My name's Keith Willett. I'm the Medical Director for Acute Care in NHS England. This is a webinar all about working with local government, and it's very much a clinician's guide. And it's come about because out there in the Sustainability and Transformation Partnerships, we've been asked by many of the clinicians to help them understand how local government works. They know that interface is really important, and they want to understand more about how they're set up, how the roles and responsibilities play out, what's important to them and how they operate. So this evening we've got some very experienced guests with us, which I'll introduce in a moment. But we're going to try and work our way through some of those things and also take your questions. So as a webinar, you will see that on the screen there is a chat marker, and in the bottom right hand corner there's a box where you can type in questions. So please do submit questions as we go along. We'll collect those together and I'll pass them over to our guests. I think in general we can all recognise that there's a lot to be gained from working together, but there are some inherent differences. The approaches we take are quite different, and we know from the past there's some real sensitivities in some areas. And that's particularly in many of your experiences as clinicians. It may be preparing for or facing a scrutiny committee. So we're going to try and cover many of those aspects, but also, as I've said, any aspect that you want to bring up with a question, so please do think about submitting them. Now, we have two counsellors with us this evening who are going to help us, and they're going to answer the questions for me and for you, I hope. So I'll let them introduce themselves. So it's Richard Kemp and Johnny McMahon. Richard, would you just like to say what your role is and your experience?
Yes, I'm Cllr Richard Kemp. I'm from Liverpool City Council, where I'm the leader of the Liberal Democrat opposition. Nationally, I'm Deputy Chair of the Community Wellbeing Board of the LGA, which looks at our health and social policy activities, and I also serve on the Health and Wellbeing Board of Liverpool City Council.
Thank you very much. And Johnny McMahon.
I'm Johnny McMahon. I was a GP. I retired from practice in May 2015. For the couple of years before I retired, 3 years, I was chair of the Clinical Commissioning Group, and I was co-chair of the Staffordshire Health and Wellbeing Board. After retirement, I became clinical lead for cancer end of life in the county, and then stood for election, and I've been a councillor since May of last year. And since being elected, I've been chair of the Health Scrutiny Committee in the county.
So I think between our two guests this evening, that gives us a real opportunity to ask questions that cover everything from health across into the national experience of Richard at the national level with the local government. So I think it's safe, and I'm looking at you in the eyes here, to say that I think we can start with the premise that most clinicians, and in fact most people in health, really don't have a good understanding of local government structures, what motivates them and their accountability. And I think that's because we start from very different places. And I'll be honest, I've been working a lot now with local government, social care, the community, in trying to understand the urgent and emergency care services in the NHS. And I think fundamentally what's different, well, organisationally, the NHS is very much a top-down structure. We're used to receiving directives, we're used to playing things out in that way, whereas local government is very different. It's grassroots, it's from the bottom up, it's a very, very different thing in organisationally and accountability. But also personally, I think the clinicians and health come at this very much from a patient focus, evidence-based interventions, doing the right thing for individual patients. But from local government, it's different again. That's very much about being responsive to what their public tell them they want, rather than necessarily what they, as in health, would say, we know what's best. So I think that's quite a difference in approach. And I think we'll see that play out as we address some of the questions this evening. So to put a bit more structure around that and say some evidence of, is he just making this up, or is that what the communities out there in health and local government think, there's some evidence to be published shortly from Britain Thinks, which is a insight and strategy research survey that's been done of professionals in both organisations. And in general, there's an agreement, commonality that the principle of integrating health and social care is the right thing to do. moving to a place-based approach for both organisations makes a lot of sense. But our past experience of that interface hasn't necessarily, I think, been good. We've certainly had some views, and coming back from local government, views about how the NHS has approached local government and social services in the past, is the NHS tends to engage very late. The NHS also comes with quite a narrow focus about its agenda and its problems, rather than really appreciating the fact that local government has a much wider remit. A lot of the social determinants of health outcomes lie within local government, be that housing, be it drug and alcohol services, be it family, children's centres, the sort of things that perhaps we don't recognise. But also the NHS has been probably quite weak at collaborating in the past, and probably doesn't have anywhere near the same experience, for the reasons I've said, about how to consult with its constituents and its public, which local government have vast experience on. So I think there's an awful lot of value to be had in a strong relationship between health and local government. So that's what we're going to try and explore tonight, but clearly there are some specific questions there. And I think if we just reflect back, as those of us who come from a health background, is that if we look back at Better Care Fund, we look at how we set up the STPs to start off with, I think that those processes probably reflect some of the narrowness that health took, and why local government in some places was a little reticent to buy in to some of those processes. And I think we're still working through that in many areas. Also, we've got to be sensitive that NHS, although yes, we've been financially constrained, we have been protected, and we've had a little bit of growth over the last 7 or 8 years, whereas local government has seen a very different perspective. They have tried to protect adult social services, but they've seen cuts like we couldn't imagine that they've had to handle. So I think we all need to be aware of some of that. So I'm going to move on now to get Richard and Johnny to talk about some specific areas. But again, do look at your screen, bottom right hand corner. If you've got a question you want to raise this evening, please type it in there. We'll be picking that up, and we'll have an opportunity to feed that back in to our guests later on. So if I turn to Richard first. So Richard, the roles, responsibilities of local government, elected members, other officials, how does the whole structure work for those of us in health who aren't day-to-day interfacing?
Well, you used a very key word there, and that was elected. And that, of course, is the key difference between me and the member of a clinical commissioning group or a foundation hospital, whatever it is. I've been elected, and with 89 other people in my case, we've been elected to Liverpool City Council. We have put policies and proposals through to the people of Liverpool, and at the moment they're not backing my party, they've backed another, but enough of them back me to give me a place to raise my concerns and to do things within the system. And that means we have a tremendous leadership of place, because no one else, apart from the 90 of us, has been elected to deal with the problems of Liverpool. Now, you might say you then just deal with local council services, don't you? But if I can give you the example, when I came here today, I got the 86 bus into Lime Street Station to catch the train. It's the last bus stop that goes on the route that goes through my ward, and it's like doing an advice centre. And I got 4 problems given to me today, none of which related to the running of Liverpool City Council.
Or the bus.
Or the bus, yes. The bus was on time, very good bus it was as well, thank you Arriva. But that is an indication. We go out of the door and we are in our wards, we are dealing with people. It can take us 2 hours to get a loaf of bread. So even if we're not directly responsible for it, and we are responsible for most of the social determinants of health, we are expected to deal with whatever issue comes up. And I always say that I've actually been a health service worker for more than 40 years now, because I think we should redefine the roles. Because I think you lot work for the National Illness Service and I work for the National Health Service. Because just imagine, if everyone in this country lived in a decent house, in a nice neighbourhood, a decent job with a few bob in their pocket, how many people would be obese? How many people would be presenting with a whole range of illnesses? So my job is to keep people well. Now that means we have very complex ways of dealing with this, and in fact the system is different between me and where Johnny works. I'm an urban area, we're a unitary council, we're now part of the combined authority for Merseyside. We have a regional mayor as well as an elected mayor. But there are certain principles which carry through all that. At the heart of every council there is a cabinet. It might be called something else, it could be an executive, but that's where the councillors from the controlling party representing all the disciplines make the key decisions. Then you have a series of structures, Johnny will be talking more about scrutiny, but including full council, where people like me hold the council leadership to account. But again, many of our debates inside the City Council do not relate to our work as a council. They relate to anything which might affect the people of Liverpool, and clearly health is one of the things we often debate and discuss, not always as fruitfully as we might, but that is our responsibility. So we have, for example, the Health and Wellbeing Board, which is where the clinical commissioning groups and ourselves meet to look at policy. We are responsible for the Joint Strategic Needs Analysis, which is a health document, but doesn't just apply to the health service. It applies to the bus service, it applies to the housing services, it applies to the leisure services. Our job is to promote health using that information everywhere, and the health service is part of it. We of course control public health, although we have massively reduced budgets to do this. And the most common interface that clinicians think about is adult social care, where we are trying to get people back into the community as well as we could. Is this working well? Well, partly in your introduction you alluded to the circumstances in which the STPs were created, and frankly they couldn't have been created in a worse way for local councillors. Because and the health service for that matter, because frankly, if the first thing I know about a proposal from the health service or anywhere else is when I read it in the paper, then I go into opposition mode. If people talk to me and show me the reasons that things need to happen, I go into a supportive mode. I won't necessarily support exactly what any organisation wants, include the health service, but I become far more positive. And the fact is, we've done our own survey of elected members, but by and large, councillors are not involved in the STP process at all. There's some in the health scrutiny will be involved, there'll be others who do relate to this, but less than 10% of councillors actually know what STP is.
So can I just interrupt you there and just challenge you? So that's really important, and I think there was the sensitivity about the STPs and the pace at which that happened. I think many of the clinicians will recognise, and they've sort of worked through that already, I guess, in many places. But I think on the corollary, there is the obviously you've gone through in local government significant funding issues, and many of the decisions, although I've said in introduction you've tried to protect adult social care and other elements importantly, many of the decisions that have been made in local government have a direct effect equally on health. Indeed. So could you just explain to clinicians in STPs how that sort of process of financial accountability goes on in local government, and how you would take the soundings from health and the NHS, if you like, about the impact it may have in the other direction?
Well, we do it in a number of ways. Principally, we do it through the Cabinet and then into the Health and Wellbeing Board, because there we get papers from the Health Service and various parts of the Council, the Fire Service, the Police, in which we challenge each other in a very positive way. Yep. So this isn't antagonistic challenge, but to really ask some of these key questions. If you do that, what does that mean to you, and what does that mean to you? So we do try and reach a consensus of a way forward. But there are difficulties to that. Liverpool's budget, for example, has been cut by 50% in real terms.
5-0. Yep.
5-0
yep.
Since 2010. And we've looked with envy at the at the NHS, you've lost a bit in relative terms. It's not as much as you wanted, which is slightly different, but you haven't lost that much. And I find that the biggest problem we have dealing with the health service is the way that not only clinicians, but everyone in the health service retreats, not into the health service, but their own bit of the health service. So, for example, in Liverpool, the voluntary sector funding from the health service was cut by 50% in one chunk last year. Now, we know that that will have immediate effects in our communities, and we know in a year's time that'll have a big effect on the health service, and in 5 years' time it'll have an even bigger effect. But we talk to people because we take a long-term view. I'm making decisions now in terms of roads and housing and things which will affect people in 30 years' time when I'm dead.
So 2 questions then.
Yeah.
So firstly, for the clinicians, those who are in leadership roles in the STPs, what's the best route of contact for them to understand the decision makings that have gone on in the recent past that they may need to be taking account of? Is that the minutes of the Health and Wellbeing Board? Where do they get that information? So that's sort of the first question. And on a more positive note, now relationships are forming, and it's all about relationships. I think you'd agree with that.
Yeah.
This is all about relationships. I mean, we know that sometimes the STPs were the first time some local government and health people had even sat in the same room. So if we're moving forward positively, then where can they find out what happened in the recent past together so they've got the context right? And then secondly, what's the route now that really gets the engagement going, and who should the STPs really be engaging with within this sort of plethora of roles and elected and non-elected people within local government?
Well, what I've described so far is the formal system. It's where we have meetings, it's where we have committees, it's where we have duties. But the best place to do it is possibly the pub or a cafe or a restaurant or an informal meeting place, because I want to get into the heart of some of these issues, very difficult to do in a report. And I will often challenge things. I do some training sometimes within the health service. Say, hands up any of you here who know a counsellor. Well, every single clinician has a local counsellor. Every single clinician has a council leader, or in some cases an elected mayor. There are all sorts of ways that they need to break into the system and create those relationships. And perhaps one of the key ones would be, for ward councillors, would be GPs. So if I'm faced, let's say, with a hospital closure, who are my constituents going to talk to first? The GP. What do they then tell me? Do the GPs interact with me and say, hey, councillor, there's some questions I've got to ask about this. I'm quite in favour, I'm against it, whatever it is. So what is the route? But that's me as a ward councillor, and every councillor, including the leader of the council, is a ward councillor. So I would encourage clinicians to develop relationships. I would be inviting every councillor in North Merseyside, because although we have an SDP, we're largely doing this in North Merseyside. Why isn't the NHS calling meetings for people to get to know each other?
So this is very much bi-directional, isn't it? There's a lot that the councillors need to learn from the health, from those who are thinking about transforming services or providing services in a different way, and actually doing that needs assessment from what inevitably from an illness service is quite narrow. But there's very much a role for them to understand the best routes in to get the right consultation in place, so that they're actually making decisions that are likely to hold up under scrutiny. And we'll come to that later with Johnny.
That's right. The more I know, the more I can help. So if a hospital is going to close, and we might have that, the first question I ask, so we've got a problem with the women's hospital, the first question I ask is, what's that going to mean for my wife, my daughters and my granddaughters? And if people can come up to me with evidence to say, clinically, these are the things that would help your daughters, granddaughters, etc. life, then I will respond much more than someone saying, we've got to close it, and I think the buggers are trying to save money.
And I think that's a really good example, because as a clinician, we'd be saying, what's the nice guidance for that cohort of patients so that we're doing the right thing? You're saying, no, actually it's about my constituent, my family. What does it mean for them in terms of travel access?
But they're
support?
the same people
They are
at the
the
end
same
of the
people.
day. And that's why we need to come together in the middle. And it's a nice guidance. I occasionally have to read some of it. I wouldn't take it into my ward to discuss it with people there. We need to demystify some of the health service stuff. And if I could ask everyone who's watching this, whenever you watch it, to be braver. And if I can just give you a very brief example of that. We had a health and wellbeing board in Liverpool, and we were picketed, and people came up making all sorts of accusations against the elected mayor of Liverpool. And it would have been easy for me to say, well, that's good, because he's a different party than me. But in fact, he was being unfairly attacked on clinical grounds about why we try and stop people going into hospital, because we want to keep them healthier, and why we try and get them out as soon as possible, which isn't financial grounds at all, although that has a part. So I waded in on behalf of the Labour leadership of the council, and there were clinicians sitting around who could have made a much better job of it than me, because actually people do believe doctors, but we think doctors are God, and they all sat there. And I said afterwards, why didn't you come in on that debate? Well, we thought it was political. Well, I'm afraid, clinicians, you're going to have to get your jacket off, roll up your sleeve and go out into the communities, because if you set the right clinical tone to some of the debates that need to be had, people will listen to you more than me. Do not hide behind my skirts.
So we've had a question sent in, and it's about, and you've answered a lot of the questions that have come through, which is great, so don't take these individually, but we've had come in saying, what is the memorandum of understanding between local authorities and the STP? And how is that sort of agreed in the council or the local authority as to how you approve that?
Well, basically, there isn't one. So in all cases...
Is that just for
No, this is generally.
Generally.
The SDP has come to the council as a document which was completed in 15 months, was it, whatever,
yep.
And it comes to the Health and Wellbeing Board. The council may then choose to take it as a document to council for discussion, but the legal place it goes is the Health and Wellbeing Board. And then it goes straight into the scrutiny process for the scrutiny people to look at what's happening day to day. There is a danger to that, though, is that by law, the people on the scrutiny committee cannot be in the cabinet and the senior decision makers, because that's the split, exactly as we have it in Parliament. So precisely what happens varies from council to council. In my own council, for example, we oppose the STP, but we're getting on with the job of delivering the North Mersey Health Plan. So because we'd already signed that off, we agreed that.
So is the answer, you know, if we were going through this again, and obviously we're now into a much more positive place with these relationships, is it about finding the common ground and building up an understanding and the relationships on that, and then recognising each other's particular issues and trying to co-create solutions? Is that what we should be doing?
Absolutely.
Rather than trying to write memorandums of understanding documents?
We want to help the same people. You call them patients, I call them residents. We're all there for the same purpose. And my job, someone said, well, what are you good at? You're good for nothing. This was someone who wasn't being particularly kind to me, and it was rather ruder language than that. I said, I am not an expert on anything except joining things up. So we have 480 different professions in local government, never mind interacting with the health service. That isn't my job. My job is to say, what's the health service doing with the housing department? Why aren't you using our parks to better effect? Because that's where I can see real physical and mental health benefits. I'm a joiner-upper.
So this leads us nicely into Johnny, so I hope you're warmed up, Johnny. So what's coming out of this, if I can just sort of paraphrase what you've said, is there is something about what the NHS comes in terms of its ask and the narrowness, which you've very nicely explained how that doesn't fit with what necessarily the local government's agenda might be. So there's that element to it. And I think the experience you have of working with your constituents and with the public is so much different. So one of the things I think that's dawned on me over recent years is that when we get into slightly more contentious transformations in health, we tend to put out our clinicians, and many of them will be the STP leads now, out into public meetings or whatever, and we give them sort of a briefing, which is what I call designing for the usual, which actually most people understand. That certain services need to change because that's where you get the best outcomes and the best survival. But what we don't tend to address, which is I think what you've said, is what's the plan for the unusual? You know, what does it mean for my wife who happens to have multiple sclerosis, who lives in a one-bedroom flat and is on benefits? What does it mean for the individual? So we don't do it, and so we often find that we put our clinicians up in front of scrutiny committees or up in front of public consultations, and they're not briefed in a way that reflects what's on the desk. So Johnny, can you sort of give us an idea about a clinician's guide to how a scrutiny committee is formed, what it's thinking, what it wants to hear, and how we should be preparing ourselves?
Well, it's the council as a whole that's responsible for scrutiny, and the council, usually under the leader, will decide how they want scrutiny to work, what the different parameters for the different scrutiny committees are, and it came into being, I think it was after the 2003 Act, which brought cabinets into local government, and therefore in order for that to be done in a way that was with proper governance, they put the scrutiny arrangements in. The net effect of that is effectively to scrutinise what happens in the county council. For instance, adult health will clearly come under a health scrutiny committee. But councils also have the powers to call in external agencies, not just health, but health is the only one that's done with any degree of frequency and regularity. They could on occasions call in utility companies and Highways England. But because the only external agencies that are regularly scrutinised is the NHS, the Health Scrutiny Committee is of a different order, both in terms of magnitude and complexity within which it works. And the other scrutiny committees, well, they understand each other a bit better. They come from the same culture, and we come from you know, we're challenging and putting scrutiny into an organisation that has a very different culture. When I first became the CCG chair in Cannock, I had to appear before the Health Scrutiny Committee, and you're quite nervous to begin with, and I went in there and came away, and forgive me, but I was immediately reminded of Margaret Thatcher's account of being challenged by Geoffrey Howe. It was like being mauled by a dead sheep. It seemed to oscillate between the unreasonable and the pointless, the questions. And that's simply because the people around the table didn't understand the system. There was no lack of intellect around there, there was no lack of will, they just didn't understand how the NHS worked, therefore they couldn't give us challenging questions. And I'm sure that many folk who are listening will resonate with that. Well, I would say to you that the lack of understanding is equivalent to your lack of understanding of how the county councils work, and unitary authorities and district councils. It's as complicated, and with that different structure becomes a very different culture, as has clearly been outlined. So I came away wondering whether, to put it bluntly, some health knowledge might help the scrutiny, and that's when I started thinking about becoming a politician after retiring.
So do you think in the future, going to a scrutiny committee, if we've done that collaboration, that health has come, the NHS has come with a much broader understanding which has been modified by all the potential opportunities that this does, that it will be a combination of health and local government going essentially to the scrutiny committee, that things will just make much more sense on both sides?
I think that's eminently reasonable, but I think we're a bit away from that yet.
So how do we get there?
Well,
what do we need to do?
I think one of the things we need to do is both parties recognise that they don't understand the other.
Yep.
And actually sit down and start to have discussions about how things work. Now, I'm in the unique position of where I come from, and after we've had a health scrutiny committee, I spend about a quarter of an hour, 20 minutes with the people around the table. We get an A board, we say, this is how the money works, this is how GPs are employed, this is how the system is regulated, and explain the difficulties that brings about, and how it's very different from local government. Well, I see no reason why STB leads can't be invited into councils and asked to do exactly that. And it's a two-way process. The same thing happens from us teaching health about how local government works. I think that understanding, it won't solve the cultural differences overnight, but it'll be a good start.
So if we look at the STP setup and look at what's going forward and the opportunity to do the things that you've suggested, the STPs, and I've done various events with STPs trying to do some of that, learning and the education side of it, there's been a gross imbalance between the representation of health and the representation of local government, I think, in all of them, with local government being by far the minority. But on the health side, you get a sort of mix of providers and commissioners, and you get a sort of a collective. Because the local on the local government side, and particularly the provider landscape in social care and in the community and in home care and lots of areas of local government and in the utilities, everybody else, there's a much broader church of organisations that perhaps health needs to understand. Can they just do that through local government, or should STPs be having conversations not just with councillors but with the providers that support local government services?
Well, if you're doing it area by area, the council is the obvious place to start the process. Okay. But there are lots of players, but within most areas they are corralled by the council because we are used to working across disciplines. So in fact you could say, look at all those bits of the council. Don't we need someone from the leisure services, from this department, from that? Well, the answer is no, because we've produced coherent policies, so one or two people can represent the council because they can represent all those parts. For the big strategic discussions, you would then get into greater detail. But of course there are a range of players. I mean, the one that I particularly relate to, I think is very important, is the voluntary sector. We depend on the voluntary sector more than we've ever done before in councils, but increasingly I think the health service is going to depend on volunteers, you might call them. We all depend on carers. Some of them are paid carers, most of them are unpaid carers. You know, if all the carers stopped work, this country would grind to a halt. But I would say the council is the first place.
Because I think if we went to the health community and said, you know, who are the dominant players, and you know, fully respecting the CCG role, Johnny, from where you were before, but I mean our big acute providers have got the upper hand. I think people would recognise, and then you've got, you know, smaller part players which are probably the next to the community trusts, and then people like the ambulance service who are absolutely at the interface and central, to my view, have a much lower position in it. So that's how health is sort of set up. But you're describing to me really that local government is very much front and centre. But we know when we try to interface other than a government level, which is where health usually interfaces, you know, there are 12,500 care homes across England, of which the vast majority are small family businesses running one or two institutions. We've got more domiciliary care providers in England at 8,500 than we have GP practices, and most of those are small SMEs or small companies. So the health, when it's functioning, is trying to relate to this what appears to be a really complex landscape, and I think then to sort of retreats back and just sees it all as a as a big sort of amorphous cloud and doesn't know quite where to go. So local governments very much where they need to go, and then you will steer STPs into how, if they need, they need to work with care homes, or they need to work with family centres, or whatever it is they're talking about.
In almost every area there is already a grouping where the council meets the domiciliary care providers, the residential care providers, the children's centres, the specialist charities, the residents groups, the amenities groups. We're there. We can make those systems work for you and with you. And we replicate that at a national level. Last week I met the UKHCA, who are the domiciliary care providers, at a national level, because we then issue guidance, we do joint publications with them, giving support to our members and there. So the council is the way in to any community. Now, I'm not saying that you can only deal with the council by any means. I'm saying they're the way in to create the appropriate discussions. And this involves the investment. And the thing you have to invest most is the investment of time. You see, if I was in the health service and I wanted to do something which might be considered a bit nasty, the last thing I would do is just turn up with a report. Because I've known for a year that this could be a problem. I would have gone along to the scrutiny committee, and this doesn't happen enough, with a problem. We've got a real problem with dealing with the care of the elderly in X part of the borough. We think this is because, can we share some thoughts with you? Can we share some thoughts with the ward councillors? Will the ward councillors arrange, not public meetings? I would advise all your clinicians never to go to a public meeting, because they can all be subverted by nasty people like me. 3 people can derail public. Go for proper consultation. Say to the council, we've got the problem in this area. Will you arrange an appropriate consultation process for us and with us? So I think most people would be delighted to be involved in that sort of discussion. But you turn up with the reports I've only seen when the agendas were published, then you'll have discordant conversations, because I've gone on to defend what's there, because I haven't had the opportunity to look at all the options and the alternatives.
I agree with that entirely. I think coming early to the council means the council doesn't get any surprises, and they'll get a far more positive response. I also think in terms of scrutiny with STPs, it lends the opportunity for scrutiny committees to exercise their overview function, which is often forgotten, and can actually contribute to the process of the end result.
So just explain that overview function for those who aren't familiar.
Well, if I take an example which is not related to the STP, but it's an example that happened to us earlier this month. The health checks that the NHS the County Council is asked to arrange through public health. We've looked at the lower super output areas only, which are the technical term for the very deprived areas within our patch, and the cabinet member was conscious of the fact that this could be subject to challenge because it doesn't cover everybody the way it's supposed to. So we said to them, well, if you approach the CCGs, who are now co-commissioning primary care, and try and persuade them to commission our primary care colleagues to look at those with a high, strong family history of ischemic heart disease, using the Q-RISK-2, which factors that in and all that sort of stuff. Then basically, if you can get that, you've covered the deprived, you've covered those with a strong family history, and the chances are those that you've selected out are the worried well who you didn't need to see anyway. That's the proposal we made, and they're looking at it. Now, I just think that's an example of where we can be a bit more positive, or not on the back foot, scrutinising stuff that's happened all the time.
So, I mean, for the clinicians listening to what you've both been saying, I mean, if I was listening in on this, I'd just think, well, there's just a plethora of places that we could go to learn new stuff. There's opportunities to do there, but, you know, the reality is, being pragmatic, we're going to have to find some things that are really important and that are common to both. So we come up with some sort of shared thing. So, Johnny, perhaps in your experience, CCG, now councillor, where do you think the fertile ground is that STPs should probably be looking in general to find the right sort of wins that would be very, very popular on both sides of this relationship? It's a tough one.
Yeah, that's a big ask.
I mean, you can use
well,
local.
I think it's your remit, frankly. I think if we could start out emergency care, both sides would be very happy.
But I keep saying that the solution to emergency care problems in a hospital is not in the hospital. You know, the solutions are, you know, the elderly patient who has a innocuous fall at home, but lives in a, let's say, lives alone in a flat. You know, someone can turn up, the paramedics can turn up. They're more than capable of doing that injury assessment and saying she hasn't broken anything, but she's shaken up, she lives alone, she's slightly confused, but that might be normal. They haven't got access. There's nothing they can wrap around that patient. So, you know, it's a brave stroke heartless paramedic that just plops her in a chair and drives away. You know, that's a conveyance to hospital. Further she gets away from her family, her community, her GP, her medical records, she's an admission. And so, you know, the ability to wrap around the patient, the idea that, you know, you could have a volunteer come in who could sit with the patient for that, you know, that personal support, and we could be sure that a rapid response community assessment would come in over the next few hours. Perhaps the GP or practice would be involved the following day, and a falls team review initiated if this is the third time she's fallen. If that was the offer, then I think patient, resident, paramedic, everybody would be happy. And interestingly, that's the same thing that we're trying to wrap around the patient to get them home 10 days later when they've been stuck in hospital. But now, because they've been in bed for 10 days, they're 10 years weaker in terms of muscle strength, as we were talking about before.
Yes.
So, you know, that's my sort of health view, but I'm seeing it very much from one end of the telescope. Is that the sort of places that people should be starting, or do you think it's got to be simpler than that to begin with?
Yeah, I think you've got to find some easily understandable things and make a success of them. So let me give you an example. We all know, and it varies from place to place, but Friday nights, Saturday nights, Thursday nights, and then Wednesday it's student night in Liverpool are dreadful places to be in A&E. And that's why we have the paramedics are trying to get away in 10 minutes from the old lady who will always, in my view, need caring. So let's look at what we could do. Now, the obvious answer is let's take on 2 more consultants, 3 more registrars, 5 more nurses, build a new, etc. Well, that is an answer, but wouldn't it be better to work with the police, fire service, licensing department and the council to find a base in all the areas where there's high drinking, where we can deal with people, triage people on the spot to stop them going to accident emergency in the first place. Now that takes a view that it isn't an institutional answer, it's a community-based answer. It involves all the relevant authorities, it's cheap and it's quick.
And interesting, those alcohol intoxication management services, AIMS, are now being studied by an NHR research grant to give the clinicians the evidence that they need to say that's the right thing to do too. So, I mean, that's an example, but because I think if you'd thrown that out as just a statement, and before the question comes flooding into my desk here, I'm sure somebody out there is saying, yeah, but the local authority has reduced the drug and alcohol abuse services in my locality, and that's part of the problem. So,
and it is.
And so again, that's where there's an alternative, but we'll get to the right answer through that shared response. Is that a good example?
Yes, because if the council, the fire service, the police service and the accident emergency and the hospital trust say something, then you're much more likely to be able to find a way of getting funding for it. And you can actually show that if we do this, and there is some experience about it, we can prove the number of people you can keep out of the accident emergency units and actually say that would free up 20% of your beds, whatever it is. And this is a cost-effective way of doing it, and it's one that we can act on. Because dealing with a big institute, are we closing a hospital, are we creating we're talking 10 years, 15 years. I don't know that the Royal Liverpool Hospital will ever be built now since Cllr went, but I know if we all put our mind to it, blended together what little money we've got, used what powers we've got together, we could do some things very quickly.
So I think part of this, and one of the questions that's come through, which I think I understand, it's that business about the relationships, and how the NHS mustn't mistake sort of robust challenges from local government as being sort of criticisms of what we're proposing. We should almost sort of come with what's on your desk, what's on my desk, what are the problems, where's the overlap, what's the joint solution. So it's really about building the relationship before we start trying to lay solutions on the table.
Yeah.
Taking a more community collaborative approach in emergency care as an example, I think what you describe will be forced upon us rather than us deciding to do, for the simple reason that resources can be twofold. It can either be money or human resource. And in many areas in medicine at the moment, we just don't have the skilled clinicians to take the jobs. And that's why it's a question of not just financial sustainability, but clinical sustainability. And therefore, rather than getting the 2 or 3 extra A&E consultants, which might be very hard to find, we'd be forced down a more collaborative route, which I think in the long run will be better for the system.
It's better, yeah. Austerity can have its good points. It's making us think differently.
Well, to be fair, when we have money in the system, we've reinforced traditional practice, would be my
exactly,
view, rather than do the sort of transformations across the system that perhaps we need.
Exactly.
Do you have a view as to how local government, how councillors sort of see that national perspective that the NHS always has, that sort of top-down, what feels quite politically led steers as to how the NHS has got to do things, which then comes with you with sort of almost sort of constrained asks that, you know, that's what we've been told we've got to do. Does that something that is difficult?
Well, it's something we understand. We do know that the NHS is a big bureaucracy. I look around, I mean, there's one of about 10 places you've got like this, I would guess, in London. So we're familiar with that. But it does take, in my view, as a national local government figure, if I could put it that way, some changes from the government. I'm looking with great interest at what's happening in Manchester, and here's another form of governance that we haven't looked at, where much, not all, but much of the decision-making process has been given to the combined authority in Greater Manchester, led by a mayor, with a transformation fund, because I can't ask institutions to change, to do something different, unless we put some money in place in the short term to make those things happen. And there, I believe, and it's early days yet, but we're seeing much greater integration of things like adult social care, public health, housing, and the health service. And in fact, the whole document which sets this up starts off on the social determinants of health that I was talking about before. One of the key aims of the health service, well, let's call it the MHS, the Manchester Health Service, to get people into work, because so many things flow from people being into work. So perhaps we will see an evolution, but that also takes the Secretary of State not standing up in the council and saying, I take responsibility for this hospital, I'm going to sort this out. He's got to let go, but he's got to let go to someone. Does he let go to trusts, STPs? I mean, the STPs have no legal base. The STP can't actually make a decision at all.
But in some ways that's quite an advantage, isn't it? Because it means it's based on relationships.
Well, it means it should be based on relationships. I'm not convinced we're there yet in many cases. But somewhere, so you're either going to let go to bureaucrats, or you're going to let go to people who've directly elected, who can pull together. And that's what I believe needs to be done.
So in this relationship, and perhaps Johnny, I'll come to you on this, is very much a sort of a give and take, isn't it? We've got to sort of achieve that in some ways. So, and let's take the issue which many STPs will be concerned about, and I'm not want to focus on adult social care, but clearly, you know, the patients who we can't move back into the community because of either NHS waits for placement or for care packages or whatever we put together. What would local government want to see health bringing to the table? I mean, we often find that hospitals aren't very often outward facing, they aren't sort of supporting in the community. Are there things that would be really useful that if health came along with those as part of the sort of, because we're talking about a negotiation at the end of the day here about what we can both do for each other. what were the things that you would want health to be bringing that could substantially benefit the social care and the local authority and the structures?
I think it's two things. One is come to the table as early as you can, not come late with what can be perceived as a fait accompli, because that just doesn't work. The second thing is I think there is something about responsibility and where responsibility lies, and I do think the primary secondary care split in health, which has been an anachronism for decades, really accentuates that. And there's something about hospitals and consultants taking on a role for patients actually in the community rather than just seeing them in outpatients.
That's what I meant by outward facing.
Exactly.
Rather than perhaps complaining about what's not going on in the community, actually supporting that.
But likewise, GPs take an active interest in their patients when they're in the hospital as well. And I think with modern technology through Skype and all the rest of it, that's perfectly feasible. And that mutual approach, I think, would be of help to all parties, including the local authorities.
Because presumably health is seen as quite an anxiety issue in a lot of the community supported services, where there's a question, is this got a health element to it? And you know, at the moment, the only way the NHS offers local government a response is by usually moving patients up a pathway to a higher acuity, higher cost setting, whether that's even into primary care or community care or secondary care. And that's sort of our response, which is probably the last thing you want to be doing, because actually taking the patient, taking the resident, the constituent away and then trying to reintegrate them is a much bigger ask.
Yeah, I mean, the question that I always ask, and I would guess almost everyone in the health service asks this as well when I look at adult social care. My mum died 3 years ago, but I always say, would I have let my mum go through this?
Yeah.
And that looking after your mum actually isn't a bad thing, because at the end of the day, all these people are people. They're not numbers, they're not statistics, they're people's mums, they're people's daughters. And we therefore have to relate things in a very human way. But I think by doing that, you can often get a good coming together of the health and local authority and other communities. So if you want to do something, you say, your children at the moment can't get this, but they would be able to if we did that. Because we go in to defend what they're going to lose, because we don't have a good enough idea about what they're going to get, what the alternatives are. Now, I don't think I've ever met a consultant in my community at all, unless I've bumped into one in the pub or something like that. Why aren't clinicians leaving the hospitals to see people actually in their communities, to understand more? Because I bet they go back to the sort of places that I represent. I represent one of the wealthy parts of Liverpool. What do they know about life in Liverpool 8 and Toxteth and the social determinants that we're battling to meet?
So that's one of the questions that's come in is, and I guess this is very much for you, Richard, it's how do the big unitary authorities provide a multiplicity of care models to suit the diverse local care models that are needed?
Well, the fact is that even our big unitary authorities, or even our counties can represent 1 million people, actually don't work as one body with one set of policies, because we're small enough to be able to define a whole series of different policy interventions. So very simply, I represent Liverpool 18, Penny Lane, there beneath the blue suburban skies. I used to represent Liverpool 8. The life expectancy, 3 miles apart, is 12 years. We recognise that. We recognise there are differences in some of our ethnic minority communities. So our approach to dealing with health isn't a set of clinical options. It might be to say we're going to work with the Somali community, and particularly the Somali women, about some issues. In a wealthy area, there are a different set of issues. For example, my wife, when she was the Lord Mayor, created a system so that ours is a dementia-friendly neighbourhood involving the banks and the shops. And we could do that because you could clearly identify dementia as an issue and a solvable issue, because money isn't the problem in my area. But to do exactly the same in Liverpool 8, we might have needed to create a partnership etc., etc. In Liverpool 18, we could just do it. So we're big enough to have some push, particularly if we get together in the combined city region areas, but we're small enough to be able to differentiate service.
And we've had another question, which is very much a step aside, if you like, but it's helping the STP clinical leads understand PERDA and the impact that will have on timetables and what they're planning to do. It's something obviously we're aware of nationally because we have that, but what does it mean locally for things moving forward and plans?
Well, it basically means you can't produce something which is contentious, which is a new policy, within, if I remember, 40 days of any election, because that could be
so that's
seen...
local council elections?
Any election.
Yeah.
So last year, of course, we had a general election we weren't expecting, so we had PERDA and for local elections, then we went immediately into PERDA for the general election. So in effect, we had something like 2.5 months, because otherwise it is seen quite rightly that a controlling party, nationally or locally, could slip things in to win votes. And that's why it's not done. That's a sign of the strength of our democracy, that such a thing can happen.
Okay, great. Well, I think we've covered just about most of the areas that have been raised and we were anticipating this evening. I'll just check from my team that we've got no other questions that have come forward that we need to pick up. No, you've obviously done a comprehensive job, gentlemen, so that's fantastic. I'm just going to come back to you in a moment and just say, your last 2 minutes, what messages would you leave with the clinicians who are leading STPs that you'd like to leave them with as a parting message? And I think if I could just summarise some of the things that I think we have covered there, and I'll try not to get into your 2 minutes, but for me there's something here about getting over that fundamental weakness that we have in health, about understanding the wider health and wellbeing opportunities that sit in local government and the wider health determinants that I think we really miss out on enormously the opportunities, and we've had some good ideas about how to get into some of those. I'm sure one of you can say something about the timing of approaches, but this is about, for me, it's about the relationships and co-creation. Not a word I particularly like, but it's doing this together for mutual benefit for all the people that we serve in a public. And for me, it's also about something about just respecting that we come from different places and that we aren't going to argue and necessarily think and approach things in the same way. And we need to just stand back and listen rather than make assumptions about how you're going to come up with the answers that we are asking. And we do this together. So, start with Richard. What messages do you want to leave with the clinicians leading STPs? Right,
well, I hope one of the things that's come out of this is that people like Johnny and I are actually human beings. We don't bite anyone's head off. Most councillors are rational. I can't say all of them are, but most of the councillors are rational. And we go into politics for one reason. It doesn't matter which party we're in. We certainly don't do it as local government to make money. We do it because we have a passionate interest in our community and the people we serve. Now, you can either choose to harness that, or you can choose to ignore it and take us on. Taking us on isn't productive, because I can be really aggressive. You should see what I say to the leader of the council, never mind the health service. Or you can inform me and involve me and make me your ally. At the end of the day, I don't have a hard and set view about what my services, my constituents need. I don't have a hard and set view about the way they should be provided or who provides them. All I want is the best for my constituents and for the people of Liverpool, because I'm a city councillor, not just a local councillor. So come and use us. And we've got a very good venue in Liverpool because we've named one of our best pubs after the world's first medical officer of health. So anyone in our area can take me to the Dr. Duncan, we'll have a pint and discuss all these things. So go and see people. Doesn't matter who you get, if you know someone, go and see them and work with them about how to break into the system, because it's going to be different in Staffordshire than it is in Liverpool.
So that's Richard Kemp's 2 minutes and wisdom. Johnny McMahon.
I think the first thing to do is to recognise each other's strengths. The voice of a clinician at a scrutiny committee is extremely powerful, and the role of good clinical leadership within STPs and their relationship with the County Council, I don't think can be underestimated. Likewise, the councils are unique in the sense that we have a democratic mandate, a local democratic mandate, and we have an overview of the whole system. And I think that should be taken full advantage of in terms of each trying to understand the system a bit better and getting legitimacy early before public consultation. I can think of one particular example where approaching when I was a chair, where approaching the county council early meant that we didn't get our fingers burnt, and we refashioned it. And it was all about altering the hours in an urgent care centre. We refashioned it. It was fully supported by the council, and then we went to public consultation, and the ride was far easier than it would have been.
Thank you very much. So really wise advice there from our two experts, and can I thank you on behalf of everybody that's listened to or will listen to this this webinar for that expertise. So thank you for listening. I'm sure both Richard and Johnny would be happy to take questions if you want to send them in offline, and do that through the STP team here at NHS England. Thank you very much.